Okay, let's jump right in. 10 high-yield cases, rapid review style. First up, internal medicine. And our first diagnosis is menopause. So the diagnosis here is menopause. And the key clue? It's that classic triad of symptoms. A 48-year-old woman with hot flushes, insomnia, and mood changes. That clinical picture just screams menopausal transition. So what's happening here? Well, the ovarian follicles are running out, which leads to a big drop in estrogen. That drop removes the negative feedback on the pituitary, and that brings us to the clinical pearl. Menopause means you've got low estrogen, which causes a spike in FSH, that's your most sensitive marker, and also a rise in LH. Okay, on to our second case. Diagnosis: high output heart failure. The dead giveaway, the key clue, is this combo of findings. You see bounding pulses, a really brisk carotid obstroke, and a super wide pulse pressure, specifically in a dialysis patient with a big AV fistula. This whole hyperdynamic picture is the complete opposite of typical low output failure. Logically, that AV fistula is acting like a low-resistance shortcut. It tanks the systemic vascular resistance and just floods the heart with way too much venous return, or preload. The heart just gets overwhelmed. So here's your pearl. For high-output heart failure, look for warm hands, a wide pulse pressure, and bounding pulses. The big causes, think AV fistula, severe anemia, or hyperthyroidism. All right, next diagnosis. Okay, next up, carbon monoxide poisoning. The key clue here is all about context. You have a patient with a headache, confusion, and dizziness that happens in the winter and gets better when they leave their mobile home. That's a huge flag for an environmental exposure. Now here's the trap. The pulse oximeter is going to look falsely normal. Why? Because it can't tell the difference between oxyhemoglobin and carboxyhemoglobin. So the pearl is this. If you see a patient in the winter with a headache and confusion, but their pulse ox is normal, you have to think CO poisoning. And you diagnose it with an ABG to check the carboxyhemoglobin level. Next diagnosis, vitamin B12 deficiency. Your key clue is a mix of labs and history. You've got macrocytic anemia, that's an MCV over 1,000, plus a low reticulocyte count, all in a patient with a history of gastric bypass. That combo points straight to an absorption problem. The logic is simple enough. That gastric bypass messes with intrinsic factor production, which you need to absorb B12 down in the terminal ileum. So, the take-home pearl: macrocytic anemia plus low reticulocytes in someone who's had a gastric bypass, you've got to think B12 deficiency. Oh, and keep in mind, it can also cause pancytopenia. All right, let's switch gears to surgery and oncology. First diagnosis in this section, squamous cell carcinoma. So, squamous cell carcinoma. The key clue here is that textbook high-risk profile, a painless mass on the tonsil in a man who's a long-time smoker and drinker. You really can't get more classic than that for head and neck cancer risk factors. And the logic? Tobacco and alcohol work together, synergistically, to just wreck the mucosa and cause cancer. So the pearl is simple. Smoker plus drinker plus a painless oral mass, you have to assume it's SCC until you prove it's not. And don't forget, HPV is a huge player too, especially in younger patients who don't smoke. All right, next case. Next up, pancreatic pseudocyst. Here, the key clue is all about the timing. You have a patient who's getting more and more abdominal distension and vomiting, and it's happening about 6 weeks after they had a bout of acute pancreatitis. That 6-week mark is the classic window for a pseudocyst to show up. And this leads to a really clear management pearl. If the pseudocyst isn't causing any problems, you just watch it. A lot of them go away on their own. But if it becomes symptomatic, like in our case with the vomiting, or it gets infected, then you need to drain it, usually endoscopically. Okay, on to obstetrics and gynecology. And we're going to kick this section off with a really important concept: smoking in pregnancy. Okay, let's talk about smoking in pregnancy. The key concept here is actually a negative one, what it doesn't cause. And that is hydrops fetalis. Maternal smoking absolutely does not cause hydrops. Sure, it causes vasoconstriction and fetal hypoxia, which leads to things like growth restriction and preterm birth, but it doesn't cause the severe anemia or heart failure that's behind hydrops. So to be clear, the complications you do see with smoking are things like IUGR, preterm birth, placental abruption, and even stillbirth. And that brings us to the pearl. If you see hydrops fetalis on an exam, your brain should immediately go to severe fetal anemia. Think Rh incompatibility, not smoking. All right, let's tackle our next OB case. Next diagnosis, cervical insufficiency. The key clue is a powerful combination of history and physical exam. First, the history. She's had second trimester losses before. Now the exam. She's got painless cervical dilation to 4 centimeters at just 16 weeks. That presentation, painless dilation, no contractions, is the absolute definition of cervical insufficiency. And the logic here is that this isn't premature labor. It's a structural problem with the cervix itself. That's why it's painless and happens in that classic 14 to 20-week window. So the pearl is basically an equation. A history of recurrent second trimester losses plus painless dilation equals cervical insufficiency. And the management? You place a cerclash. All right, let's wrap up with a couple of special topics, starting with ethics in psychiatry. Our first case is all about DNR orders. The topic is DNR orders and medical treatment. So here's the key scenario. You have a patient with a DNR order. They develop life-threatening hyperkalemia, but, and this is crucial, they are alert and have full decision-making capacity. So what do? The logic here is so important to get right. A DNR order applies only to one thing: withholding CPR if the patient goes into cardiopulmonary arrest. It does not mean do not treat. So the pearl is simple. DNR means no CPR during an arrest, not no treatment. And remember, a competent patient always has the right to accept or refuse any specific treatment, no matter what their code status is. Okay, on to our final topic. Our final topic, immature defense mechanisms. And a prime example of this is projection. This is when a person takes their own unacceptable thoughts or feelings and basically assigns them to someone else. It's just not a very adaptive way of dealing with internal stress. So that brings us to our final pearl. You have to be able to contrast these immature defenses, like projection or splitting, with the more mature adaptive ones. What are the mature ones? Things like suppression, altruism, humor, and sublimation. Knowing the difference between those two categories is absolutely key for your exams.